talk about vestibular rehab, has to include something about vestibular and what vestibular means. When we talk about the vestibular system, we're talking about the system that is basically our inertial gravitational reference system. So where we are in space is heavily relies upon a healthy inner ear vestibular end organ, with the primary function being gaze stability. So what gaze stability refers to is our ability to keep an image focused, keep ourselves focused on an image despite our moving head, whether our head is moving up and down, side to side, whether we're moving. The vestibular ocular reflex is our hardwired system linking our visual and our visual system with our balance organs. Let me just go back. So that's our little gyroscope, and that's located in our inner ear. You can see these three canals are each responsible for a certain direction of head motion. So head motion in this plane, head motion in this plane, head motion angular. And then these otolith organs, which are responsible for translation, so linear translation vertically, horizontally. And its neighbor next door is the cochlea, which is our hearing organ. And all of this sort of combines with the nerve fibers that come into this bundle into our, what is called the vestibular nerve, and heads into our brainstem, which is then where we talk about the vestibular system in terms of the central part of the vestibular system. So, which is a piece I'll kind of explain a little bit more later. Let's see. You get to see the whole thing. Sorry. Okay. So, everybody can see that A. Their heads are, if you're stationary in the chair, I'm sure everybody can see that clearly. So one of the things we all ask is, does that image remain clear if you're moving your head? So if you were to move your head side to side right now, and you're looking at that A, you're using the very intimate connections between your ears and your eyes. That's gaze stability. Okay? So when we talk about balance, this little slide depicts all the ways in which balance comes together, okay? Centrally and peripherally, but these two systems don't function in isolation of one another. We rely on vision, we rely on somatosensation, so the sensory fibers in our body and our muscles and joints, and all of that gets taken in and processed centrally to produce then a motor output through our musculoskeletal system. So balance is really the functional consequence of where the vestibular system is one component. So when we talk about symptoms of vestibular problems, we're talking about these types of symptoms, which is something that Dr. Heaton and I probably obsess over more than in other areas of medicine, trying to find out exactly what the patient feels and trying to get some of this terminology squared away. Are you feeling like you're spinning, or are you just feeling dizzy? Do you have a vague sense of motion or a vague sense of movement, or do you actually feel like you or your environment is spinning? A lot of people use the word I'm dizzy when they're really just saying I'm imbalanced. So terminology is important, and the terminology helps us trace back to try to figure out maybe where in these pathways the problem is. Okay? So these are all different types of manifestations of problems through the vestibular system, either centrally or peripherally. So dizziness and balance, or dizziness and balance impairment after concussion, and sort of what are the theories behind where this problem is manifesting when it comes to concussion. Some theories are that the actual peripheral component is damaged within the injury. So that little model that I showed you in the beginning of the inner ear, perhaps it's trauma to that location of our head by how the blow, depending on where the blow was sustained. So that could be a peripheral cause for the dizziness, whereas more of a central cause being injury and impact to the central nervous system, to the brain, and the more vague effects of concussion we might see. One area that is very apparent when it comes to concussion and post-concussion syndrome is the impact to concentration and attention. And that is one area that is definitely of interest to me as a vestibular therapist and also as a neurology, someone who is interested in the impact in a more global sense neurologically when it comes to effects of concussion on it. Can the person sustain their attention? Can they perform two functions at once, as you often need to do in sports? So we're looking into a little bit more in that area and how those aspects of concussion actually also affect balance. And then the last being benign positional paroxysmal vertigo, which in athletes and anyone under the age of 65, the most common cause of benign positional vertigo is a blow to the head. And what is benign positional vertigo? It's basically displacement of something called otoconia of the inner ear. So we all have these little particles that are housed in the utricle. And these particles basically make our system sort of sensitive to gravity. They're dense. And so they sit on a gelatinous membrane in that structure there. And a real bad blow to the head basically can loosen those particles and cause them to fall basically downhill. And then you have basically debris in one of the canals of the ear. So whether it's an adult athlete or a young athlete, sometimes you see post-concussion vertigo, which is less typical of a typical concussion patient who normally is feeling more dizziness. Vertigo is a very, very strong sensation, and usually with this phenomena, you see somebody basically complaining of spinning tied to a certain position. So, and that's really related to the anatomy and the fact that the displaced particle is in an area of the ear that's responsible of motion in this plane. So getting up from bed or bending over to the floor, you might hear the person complaining of a spell of dizziness, and that's very easy to treat. It's probably one of those easy aspects of concussion.
Besides a blow to a head, I don't mean to get off topic here, but what other causes
Whiplash?
for vertigo could there be? My wife has positional vertigo. Mm-hmm. She's never had a concussion in life.
Whiplash, jolting of the head. There's a certain percentage, just no known cause, it's idiopathic. After, as we age, the incidence of BPPV becomes higher. They're looking at vitamin D deficiency and BPPV. There's a correlation between osteoporosis and BPPV. So, but there is a handful where we just don't have an explanation.
She falls into that handful.
Yeah.
Her treatment on it is she'll be on the chair.
She doesn't go to YouTube, does she?
No.
Okay.
She does. She has a couple times.
So she's been to Lawrence.
Been to Lawrence and done the chair.
Good.
Spins around again, and the doctor described it like you did, putting the ball back in where it's supposed to be.
Yeah. Was it effective?
It was, yes.
So there's the definition of what vestibular rehab: functional movements and exercises of the head, neck, and body that retrain the patient's nervous system to adapt, substitute, or compensate. I did not make up those words. That is like the theoretical framework that we use to discuss, well, why does vestibular rehab help? What is it doing? And I could have a whole talk on those three words, but basically, we're trying to reset somebody. We don't know if we're going to cure an injury, but we're trying to get the whole nervous system to compensate for a problem neurologically that could exist peripherally or centrally. And so, and I'll move on with this, but the point is that there are many different strategies we use to help people, and pretty much most vestibular rehab programs are pretty customized to the person's complaints. This is one of the evaluative tools. They're called Frenzel lenses. Your wife was probably in a pair. It's basically a video infrared camera system that blocks out room light, because in room light we can all use visual fixation of objects around us to basically suppress some of the reflexive problems that are occurring in our vestibular ocular reflex. So it's a way for us to evaluate a problem that might not appear in room light. So you can see in this case, this young woman's eye projecting on a screen is one way to hone in on potentially the side of involvement, where there might be inner ear involvement, centrally or peripherally, and also the nature. Is it like mechanical, as the case in the particles in the wrong place, or is it more of a functional disturbance? So tests are performed in the frontal lenses to help tease those out. And then of course postural stability testing, and this is like a very classic and very old test called Fukuda's step test, where a person is asked, do you ever do this?
I don't know.
You ask a person to march in place with your arms out straight for 20 seconds, and the goal is to stay right in the same spot where you know, as an examiner, you put somebody on a little mark on the floor, and you give them 20 seconds. And what you're looking at is their degree of rotation and displacement from their position of origin. And let's see, if you have somebody that rotates 45 degrees, you're in the area where it's highly sensitive or highly reliable for predicting unilateral vestibular deficits. Up to 45 degrees, it's just like something we sort of, I track it, but in a healthy person that's well oriented with their eyes shut, they might travel a little bit. So we say, well, within a foot, I've had people go across the room and have no idea. They open their eyes and they can't even believe how far they travel. So what we really care about is symmetry when it comes to the vestibular system. It's symmetry. And so any type of asymmetry reveals itself either in reflexive problems or in the body's response to balance testing without vision. So this is my little laundry list if I had to try to make a list of all the things that vestibular rehab incorporates. So gaze stability exercises are like what you saw with the A on the screen, and different exercises where you focus with your head turning. Repositioning displaced calcium refers to moving the particles back to where they belong. Basically, a lot of people have heard of the Epley maneuver, which is one of 3 maneuvers really. Actually, maybe even we're sort of moving into 4 maneuvers that we could use to treat BPPV. Habituation exercises are meant to reduce motion sensitivity and hypersensitivity, which a lot of times concussion causes hypersensitivity to motion. So that's a whole group of exercises. Static and dynamic balance exercises, then you can get into sports-specific training. And then what I was alluding to, which was trying to provide opportunities for multitask and divided attention training, especially in population of athletes that have been injured by concussion. I guess an example of that could be very basically having somebody stand on foam on one leg while they recite how to drive in the car from Plaistow to Exeter. You know, you can do it a lot of different ways. You can do it with numbers, count backwards by 3 from 100. You know, there's a lot of ways to incorporate that too, you know, in the sports setting where it's a lot easier giving people 2 tasks at once. So. And then the whole concept of aerobic conditioning, and in this period where people are dizzy, whether, you know, it could be for many different reasons, where you don't want the sedentary behavior that goes along with dizziness to cause deconditioning, which can actually cause disequilibrium as well. So keeping people on some kind of conditioning program that's safe within the parameters of what they're allowed to do by their physician, and at some point when they're ready, doing more exertion type testing to determine, you know, what their threshold is, what their symptom threshold is. So, and then the education piece is huge in this area. There's a lot of homework. There's a home exercise program that is pretty much requires twice a day, usually about a 10 to 15 minute regimen over 4 to 6 weeks, depending on the diagnosis. So. There's an example of gaze stability. So that's the focusing and turning your head. You can get a little fancy and do moving objects, moving together, moving separate, and you're trying to, again, retrain or get your central nervous system to compensate for damaged side, healthy side, and that asymmetry and what it creates in terms of reflexive abnormalities with your vestibular system. So that's what gaze stability exercise is for. This is just an example of different types of balance activities. And if you remember that slide where it was the muscle guy and the ear and the eyes, and it's all about manipulating senses, so manipulating the sensory environment to help your nervous system centrally try to organize what it's using for input and what it has available, and then how it's going to produce an output. So this is just an example in a very basic context of looking at, here's some different positions that you can stand in. How do I manipulate the sensory environment? Well, the person either has vision or they don't. They're turning their head or they're not. Maybe they're turning the head and they don't have vision. And so you increase the complexity of the task, relative to the person's capabilities, and then manipulate the sensory environment. And not to get off on a tangent, but one aspect of concussion that is usually very profound is fatigue. And when you look at fatigue, some of it, yes, is physical, but some of it is also central fatigue. And if you think of something that is a very automatic function like balance, we talk about automatic functions. So functions we don't think about. I'm not standing here thinking about how do I balance. It's automatic. After an event like a concussion, you change from being in an automatic movement system, particularly with balance, to being in a willed or volitional movement system where I'm thinking now, because I'm a little dizzy, I'm going to stand like this. No, maybe this. Oh, I'm going to sit down. It's the cognitive component of balancing when you have a concussion is part of this fatigue. In addition to the body and the body's needing more rest and what goes along with healing. But so balance training is one way to help going to reset and go back to more of an automatic movement system. It's helping this resetting. And in other populations, the literature hasn't, I don't know that there's literature on concussion, but in other populations such as MS and fatigue from MS, they've shown that this type of therapy helps fatigue. So we haven't, this hasn't caught up to concussion yet, but in terms of fatigue. There are some gadgets we use, just like I said, to manipulate the task conditions. There's an exercise, he's got to do a ball circle. So he's going around, he's got to watch the ball, and he's got to bring his head down and his head up. So he's got motion sensitivity. So, and he's on foam. But all kinds of dynamic. It's fun to try to think of, depending on the person and what their goals are. It's fun to come up with a little prescription to help people in a dynamic sense. You can, this is just basic ones, but it's pretty much endless, especially if you're thinking of something to do with the hockey player who's got to go back to reffing. So that can be fun. And I touched a little bit on this, but divided attention activities. And I just want to talk a little bit about this because I'm a huge proponent of collaborative care. And so this whole model, because I think, and I don't know, maybe I'm generalizing, but maybe just strictly in the sports arena, we don't have to necessarily collaborate a ton. But when you move in the sports neurology arena, where there's so many different aspects to an injury that affect the person in so many different aspects of their well-being, really, it does take collaboration between experts. And depending on the degree, and we won't classify it, but depending on the type of concussive event and how serious it is and how long-lasting it is, you may get quite a number of people involved. And to have these resources in place, I think, is very important for an organization. It's something that we're going to be working very hard to do. First of all, to have rehabilitative professionals that work together, because in some cases of concussion, and when you're moving over the line into maybe a brain injury, Now you're thinking, well, we might need a little bit of cognitive training from a speech therapist. We might need an OT to get involved for driving. I had somebody call me once and said, my son is in high school, he was discharged from his rehab, they said he can go back and everything, but I'm not sure, can he drive? And, you know, that's a whole area which falls under OT. Do they need vision retraining because of maybe some subtle oculomotor deficits, and which would fall under OT? And then getting together and collaborating with athletic trainers, because they're the ones that are there on the front line when that athlete goes back. Working with teachers to adapt whatever needs to be done in the school. Maybe counselors because of the anxiety piece or the depression piece, depending on how long the injury goes, and adjusting to being back in school but not feeling quite right. And then obviously the medical team and the medical supervision being, you know, the top to oversee it all. Oh, this is the Banner study that showed, and this was from 2010, that was interesting because it asks a lot of questions. One of the important questions that I was thinking of when I was listening to earlier is children versus adults. And one thing that this study found was children improved by a greater amount in their self-reported, so the dizziness handicap inventory they all filled out. So on this study suggests that while children have more severe presentation and might have longer recovery, if you take children and adults who were given therapy, who got to the point of needing therapy, I think the findings were suggesting that children actually responded better than the adults. I don't know that there was a time component. There wasn't a time. Just in the end, children responded better. So there's some data there. There was quite a range in terms of age. They took adults who had sustained a concussion and children, you see 8 to 18, and all over the place as far as number of visits and number of days. So that was the duration of treatment. And they looked at dizziness, self-reported. They looked at the activities-specific balance confidence, so that's like a little bit of a lower level scale about balance. They looked at gait speed, and then they looked at performance in the sensory organization test, which your wife might have been in, I'm not sure. That's the booth where they, with high-tech force plate, look at balance. So this was the most recent study we have that shows very positively that vestibular rehab is a treatment of choice for concussion. Does anyone have any questions? Need me to elaborate on anything?
So each case, it sounds like, is pretty individual to you.
It really is.
Absolutely.
Yeah.
And probably for that as well.
Yeah. I try to, so just like there's a dosage for medication for effectiveness, like these studies really don't give you much as far as dosage beyond the intervention period was, 6 weeks. Subjects were performing home exercises twice a week. But really, within that, we don't really have good dosing. It's just been after doing this since, I've been really doing a lot of vestibular rehab since 2003. I get it. I get the dose. And you have to really be selective, especially depending if you're working on a child versus an adult, about the right combination of gaze stability, the right combination of habituation, the right combination of balance where you're manipulating their sensory environment, and then a little bit of activity, safe activity. And then making sure that you stay in a reasonable range with their symptoms. Because if they go too high, then you've lost them. And that's the case really of any age. But particularly my people after 70 and my people under 17. At the two ends, you have to keep them. And compliance in this area is huge for outcome. So I try very hard to get the right combination of work for them.